I'm Dr. Fakri Rawari, and this is urinary tract infections in adults. The basics are so important. Urinary tract infection is the most common bacterial infection in the ambulatory care setting in the United States. Nearly half of females will develop a UTI in their lifetime, with 25% recurrence within 6 months. And over half of all recurrent UTIs are caused by the same initial bacterial strain that caused the first infection. Pyelonephritis is much less common than cystitis, even in patients with untreated cystitis or untreated asymptomatic bacteriuria. Risk factors for UTIs include sexual intercourse, use of spermicides, previous UTI, a new sex partner, and a history of UTI in a first-degree female, because there are some genetic components into it. Now let's take a look at the anatomy of the urinary tract. So on the left you're looking at the urinary anatomy of the females, and on the right you're looking at the urinary anatomy of the males. Note that urethra is what's connected to the bladder, so the urine will actually exit the bladder through urethra in both females and males. So there's urethra that goes through the penis and is connected to the bladder, and the ureters connects the bladder to the kidneys in both female and males. Now in females specifically, the urethra is very close to the rectum. It's very easy for bacterial translocation from the GI. So the GI, so gastrointestinal organisms, can easily translocate to the urethra and then go up to the bladder. So cystitis is much more common in females compared to males. In males, you can see that the opening of the urethra is much further from the rectum. So it's much more difficult for translocation of bacteria from the rectum all the way to the urethra. Also look at the anatomy. So it's much more difficult for bacteria to travel up the urethra in the males. So therefore urinary tract infections are more common in females compared to male. Another thing to note is that in females, when females get urinary tract infections, the bacteria can oftentimes colonize the vagina, and in males, if males get UTIs, the bacteria can also colonize the prostate. So the prostate is also involved oftentimes when a man gets a urinary tract infection. And in men, the bacteria can also cause infection of the urethra. So urethritis is possible, as well as epididymitis. So epididymis is this area that's connected through the prostate to the same pathway. In general, urinary tract infections are divided into two categories: the upper urinary tract infections, which is primarily pyelonephritis. Pyelonephritis is the infection of the kidneys, and the lower urinary tract infection, which includes cystitis, epididymitis, prostatitis, urethritis. So the bottom three are specifically in men, and cystitis can happen in men and women. Let's take a look at the pathogenesis of urinary tract infection. So as I explained on the previous slide, is that bacteria can oftentimes translocate from the gut, specifically from the rectum, and go through the urethra. And then once they go through the urethra, they can colonize the urine in the bladder. This can cause inflammation and an immune response, specifically neutrophils, which can cause epithelial damage, leading to the burning sensation in the bladder. Now for most people, this would be the end and the infection will be resolved. However, for some people, the bacteria can ascend even further. So through the ureters, the bacteria can actually ascend all the way up to the kidneys, and they can actually colonize the kidney tissue, resulting in inflammation and damage to the kidney. There are a lot of vasculature in the nephrons, so the bacteria can easily get into the blood, and that could lead to bacteremia or infection in the blood. In general, there are 3 ways to get urinary tract infection. The first way to get urinary tract infection is through the ascending pathway, which I just described, with the bacteria translocating from the gut to the urethra and ascending to the bladder and then to the kidneys and eventually to the blood. Another way is if the bacteria actually come from the blood. So if somebody has bloodstream infection, because the blood goes through the kidneys, the bacteria can actually go from the blood to the kidneys and then from the kidneys to the bladder, causing cystitis. And the third way of getting urinary tract infection is actually through the lymphatic system. The lymphatic pathway is not as common. In fact, the evidence for it is actually from animal studies. Now let's take a look at reliable resources. IDSA is the Infectious Diseases Society of America. It's the organization in the United States that develops clinical practice guidelines for infectious diseases. The first guideline that you should be aware of is the 2009 IDSA guidelines for catheter-associated urinary tract infections in adults. This is the guideline that clinicians typically refer to for complicated UTIs. The second guideline is the 2010 IDSA guidelines for acute uncomplicated cystitis and pyelonephritis in women. The third one is the 2016 IDSA guidelines for candidiasis. This guideline includes recommendations for candiduria, which is the urinary infection caused by candida, which are fungal infections. You will learn about fungal infections on a different topic. And the last one is the 2019 IDSA guidelines for asymptomatic bacteriuria that were released just a few months ago. The first learning objective is describe the pharmacokinetic and pharmacodynamic properties of antibiotics used for UTIs. Let's take a look at some anti-infective agents that are commonly used for the management of UTI. Historically, fluoroquinolones have been frequently used for UTIs. So ciprofloxacin is one of the commonly used fluoroquinolones. The mechanism of action of fluoroquinolones involves inhibition of bacterial DNA synthesis, resulting in rapid bacterial cell death. And this happens by inhibition of two different enzymes. So they can inhibit DNA gyrase, often in gram-negative bacteria. They can also inhibit topoisomerase 4, often in gram-positive bacteria, which results in DNA synthesis interruption. Fluoroquinolones are available as PO and IV for the most part, which can be used for UTIs. Now, there are other formulations, for example, eardrops, eye drops that are not covered in this topic. Fosfomycin is only available as oral in the United States currently, and an IV formulation is under development. And the way it works is that it inhibits MUR-A, which essentially inhibits initial step in bacterial cell wall synthesis. Nitrofurantoin is also only available as an oral option, and there are three proposed mechanisms of actions for it, which include inhibition of ribosomal translation, bacterial DNA damage, or interference with the Krebs cycle or citric acid cycle. Finally, we have the combination of trimethoprim, sulfamethoxazole, which together are available as both oral and IV, which are used commonly for the treatment of UTIs. And the way they work is that sulfonamides inhibit the formation of dihydrofolic acid, and trimethoprim prevents the next step, which would be the synthesis of tetrahydrofolic acid, which in turn inhibits DNA synthesis. Now, let's take a look at some beta-lactam. So, pivmecillinam, which is an aminopenicillin, and other aminopenicillins include amoxicillin and ampicillin. But unlike those two agents, pivmecillinam is an excellent agent for use in urinary tract infections. Although its bioavailability, similar to other oral beta-lactam, is low, about 25 to 35%, it does achieve high concentrations in the kidneys. Now, this is a prodrug, so the active drug, which is mesillinam, it is primarily excreted in the urine, so 80% of it goes unchanged in the urine. And just like any beta-lactam, they act by cell wall synthesis. They bind to penicillin-binding proteins, and it is bactericidal. Now, some other beta-lactams that are commonly used in UTIs is first-generation cephalosporin cefazolin, which is only available as IV. Which has activity against E. coli, but it depends on local susceptibility rates. So E. coli may or may not be resistant to cefazolin. Ceftriaxone, which is a third generation cephalosporin and is also available as IV, has much more stable activity against E. coli. So in general, if we don't know susceptibility results, ceftriaxone has more reliable activity against E. coli. And for more severe UTIs, typically aminoglycosides are also available as an option. So gentamicin is one of them, and in general, aminoglycosides inhibit protein synthesis by binding to the 38 subunits of the ribosome. But there are more severe toxicities with aminoglycosides, including nephrotoxicity as well as ototoxicity. Let's take a look at the adverse effects of these antibiotics. Trimethoprim can lead to anemia, leukopenia, thrombocytopenia, hyperkalemia, and hyponatremia. And hyperkalemia is something that occurs in clinical practice often and is something to monitor with patients. Trimethoprim can also inhibit the secretion of serum creatinine in the kidneys, which means that artificially serum creatinine will be increased, but doesn't necessarily mean nephrotoxicity. Sulfamethoxazole, however, can cause nephrotoxicity. So because these two come together, so together this combination is considered nephrotoxic. And sulfamethoxazole, which is a sulfa drug, that component can cause rash, photosensitivity. It can also cause GI upset like nausea, vomiting, diarrhea, as well as hepatitis, anemia, thrombocytopenia. And it is recommended that the patients actually take this combination with at least 8 fluid ounces of water in order to avoid formation of crystals in the kidneys, in order to avoid or at least reduce the risk of nephrotoxicity. It is also advised for the patients to use sunscreen and avoid tanning beds because of the photosensitivity. Nitrofurantoin can also cause GI disturbances as well as CNS effects, such as headache and drowsiness. It can also lead to allergic reactions that often present as leukopenia, granulocytopenia, eosinophilia, and hemolytic anemia. And hemolytic anemia is often present in people with glucose 6-phosphate dehydrogenase deficiency. It can also cause peripheral neuropathy, interstitial pneumonitis, and it can also make the urine color change to brownish color. And with chronic use, it can also cause pulmonary fibrosis. Lastly, it can cause hyperkalemia. It is recommended that nitrofurantoin be taken with food to improve absorption and avoid concurrent magnesium products, which can reduce the absorption. Phosphomycin is currently available as oral, and it comes in packets that include powder, and the patients need to mix it with 3 to 4 fluid ounces of cool water, so it should not be done in hot water. And it can cause diarrhea, nausea, headache, vaginitis, as well as dizziness, abdominal pain, as well as rash. Now, a lot of bad things happen with fluoroquinolones in general. So let's focus on ciprofloxacin. So with ciprofloxacin, like many antibiotics, GI disturbances can occur. So nausea, vomiting, diarrhea, abdominal pain. But with fluoroquinolones, you can also have CNS effects like headache, dizziness, hallucination, delirium, and in some cases, seizures have happened, including in patients who had underlying neurological disorders, and also like patients who were taking NSAIDs. So NSAIDs can increase the risk of having seizures with fluoroquinolones. There's also been reports of peripheral neuropathy that may be irreversible, as well as arthralgia and joint pain, tendon rupture or tendinitis, and these basically occur mostly in elderly patients over the age of 60. They are at high risk. Fluoroquinolones can also lead to QTc prolongation. Now, ciprofloxacin has the lowest risk compared to other fluoroquinolones, but the risk still exists. It can also cause rash and photosensitivity. It is recommended that patients avoid taking any dairy products, so anything that includes a cation such as calcium should be avoided, so they should be separated by at least 2 hours. And just as in any product that causes photosensitivity, patients should use sunscreen and avoid tanning beds and avoid excessive exposure to sunlight. Let's take a look at different formulations of nitrofurantoin. So when first it came to the market in 1952, it was in macrocrystalline form, which, it had improved absorption, but it also came with a lot of adverse effects, specifically GI adverse effects that made it difficult to tolerate for patients. Later, by 1967, the macrocrystalline formulation was developed that improved GI adverse effects so people could tolerate it. Unfortunately, it came at the cost of absorption. So because it was not absorbed, this had to be taken 4 times a day. And this still is available on the market as macrodantin. And later, a mixture of macrocrystalline and macrocrystalline formulation was developed. So about 25 milligram macrocrystalline plus 75 milligram of macrocrystalline. So this was a little compromise. So improved absorption with a little GI adverse effect. So Macrobit, which is the preferred nitrofurantoin formulation, is available on the market, and this is 100 milligram given 2 times a day BID, and that's in the name Macrobit BID. Now, it is contraindicated in the package insert in patients with creatinine clearance less than 60. However, clinically, we do use it as long as creatinine clearance is over 30, and you can see Beer's criteria to support this recommendation. Now, here's how the spectrum of coverage of nitrofurantoin compares to some of the other oral agents. So nitrofurantoin is active against MSSA. It may or may not be active against MRSA, so it has to be tested. It is good against VRE and excellent activity against E. coli, so the resistance pretty rare. However, if it is an ESBL producing E. coli, it is likely to be resistant to nitrofurantoin as well. Whereas phosphomycin and pivmesolinam are stable, where pivmesolinam is a beta-lactam, so it's stable against ESBL, and ESBL producing E. coli typically happen to be susceptible to phosphomycin as well. So phosphomycin and pivmesolinam good options for ESBL. ESBL producing also tend to be resistant to trimsulfa as well. Now, pivmesolinam is very targeted at E. coli, Klebsiella, and some of the Enterobacterialis. And you can see that it hardly has activity against some other organisms, specifically gram-positive. However, because we get very high concentration of pivmesolinam in the urine specifically, it does happen to kill some of these gram-positives like Enterococcus, but in general, it's considered at least in vitro to be resistant. These organisms are resistant to pivmesolinam.
Because there are different formulations of nitrofurantoin, and if you're working with the generic, it just says nitrofurantoin on it. So it's important to be able, as pharmacists, to distinguish between the 2 formulations. So as you can see, choice A, it actually tells you that this is monohydrate macrocrystals combination, whereas the second is just macrocrystals. So this question is which is the generic for Macrobit. The correct answer would be A. It also tells you here, so A is Macrobit. It says that it's dosed twice a day, take it with food. Whereas the second option, it tells you, let's see, QID, so 4 times a day with food. So that's how you know choice A is Macrobit. So as pharmacists, you should be aware of, if the doctor wrote for Macrobit, don't dispense the second option, especially if the instruction says take 1 pill twice a day. You do not want to give them this because it's not going to be absorbed as much and you're going to have treatment failure.
Now let's take a look at sulfonamide allergy, which is often referred to as sulfa allergy. Now about 3 to 8% of patients report experience with sulfonamide allergies. And in general, all sulfonamides, which can be divided in sulfonamide antibiotics and sulfonamide non-antibiotic agents, they basically all contain a sulfa moiety. And then sulfonamide antibiotics also contain additional substitutions at N1 and N4 positions. And the evidence currently suggests that these substitutions at N1 and N4 are the primary determinants of drug allergy instead of the common sulfonamide moiety. So Based on the evidence that's available currently, there is a very low risk of cross-allergenicity between sulfonamide antibiotics and non-antibiotic agents. So when you hear a patient have a sulfur allergy, you should determine if it was due to a antibiotics sulfonamide or a non-antibiotic sulfonamide. And in general, sulfonamide non-antibiotic agents include loop diuretics like furosemide, thiazide diuretics, so hydrochlorothiazide for example, sulfonylureas, triptans that are used for migraine, acetazolamide, celecoxib, which is a COX-2 inhibitor, as well as some protease inhibitors for HIV, such as darunavir. And sulfonamide antibiotics, for the most part, include sulfamethoxazole, which we use for UTIs in combination with trimethoprim. But there's also sulfadiazine as well as sulfasalazine. So rechallenge and desensitization strategies may be appropriate for patients with sulfonamide allergy with delayed maculopapular eruptions. But alternative treatment options are more appropriate for patients with severe infections. We described the pharmacokinetic and pharmacodynamic properties of antibiotics used for UTIs. Now let's identify signs and symptoms of cystitis and pyelonephritis. Let's take a look at some key definitions. When you get a urine sample from a patient, for most individuals there will be no bacteria in the urine. The urine is supposed to be sterile, especially in men, and we call this sterile urine. Now, if you find bacteria in the urine sample, this could be due to contamination of the sample. This could be from the skin of the patient or from the environment. Once you rule out contamination, if there are bacteria in the urine, we call this bacteriuria. This means the presence of bacteria in the urine. If a patient with bacteriuria has no symptoms, we call this asymptomatic bacteriuria. This is not a urinary infection and does not need to be treated in most patients. If the patient does have symptoms, however, we call this symptomatic bacteriuria, or more commonly known as urinary tract infections. What exactly are these symptoms? The four most common symptoms are frequency, so the patient has to urinate small amounts frequently, and it will be painful, which we call dysuria. There will also be urgency, or the urge to void immediately, and there can also be hematuria, or the presence of blood in the urine. As I mentioned earlier, there are different types of UTIs. The most common one is cystitis, or the infection of the bladder. There is also pyelonephritis, which is not as common but is very important. Symptoms that are more specific to pyelonephritis include fever, which is not always present, but if it is suggestive of pyelonephritis. There will also be CVA tenderness or flank pain. CVA tenderness is detected during physical exam, typically by a physician as they tap on the back of the kidneys with their fingers. UTIs can also be considered uncomplicated or complicated. For example, there's uncomplicated cystitis or there is complicated cystitis. Let's take a closer look. Now let's distinguish between uncomplicated and complicated UTIs. Uncomplicated urinary tract infection refers to infection in a structurally and neurologically normal urinary tract. And the reason this is important because when there is normal anatomy and physiology, the urinary tract gets cleared much easier than when there is anatomic abnormalities. The generally accepted definition of complicated UTI includes infections in the presence of factors that predispose to persistent or relapsing infections. And those include the presence of foreign bodies, such as calculi or indwelling catheter, obstruction in the urinary tract, the presence of immunosuppression, renal failure, renal transplantation, or urinary retention from neurologic disease. These factors are important because not only do they make the clearance of bacteria from the urinary tract more difficult, but they also increase the likelihood of relapse. In addition, infection in men, pregnant women, and children, and also patients who are hospitalized or reside in the healthcare, they may be considered complicated. And more importantly, in patients with complicated UTIs, infecting microorganisms are more likely to be resistant to antimicrobial agents. And that's primarily because of these risk factors. The patients are more likely to have been exposed to antibiotics for other reasons, for other complications that they may have had. So these bacteria are more likely to have had a chance to develop resistance. We identified signs and symptoms of cystitis and pyelonephritis. Now the next learning objective is distinguish between bacteriuria, sterile pyuria, and sterile urine using the results of a urinalysis or a UA.
Now here's some definitions of different types of collection techniques for the urine specimen, and this is just for this slide is just for your information. So voided urine or random specimen. This is basically the most commonly used method by most labs. So this is basically where a cup is given to the patient and they basically urinate in it. So it's very important for the patient to not contaminate the sample. So it's important for them to not touch it. And as you can see, as you can imagine, it would be possible, as the urine is coming out, it could basically pick up bacteria from the skin. So it's possible that it could be contaminated, but this is easy and most commonly used. Another method is midstream clean catch urine, so most commonly referred to as clean catch. The reason this is preferred, but it's not as easy, is because this is less likely to be contaminated. So basically the patients are actually required to cleanse the area first, and then they're going to void the first portion of the urine into the toilet, and then the remaining urine into the cup. That way, hopefully, the urine is less likely to pick up bacteria from the skin as the urine comes out. The next method is catheterized urine. So this is basically done in patients who have a Foley catheter in place. So this is common in the hospital, especially a lot of the patients in the hospital already have a Foley catheter in place for various reasons. So if so, you can easily collect the urine and avoid any contamination. And there's also suprapubic aspirate. This is basically a needle is used to go directly into the bladder and pull urine out. So it's not as commonly used, but occasionally if there's obstruction and the patient is unable to actually urinate, and there's but the kidneys work and the urine is being produced, we can actually go directly into the bladder and draw the urine out. I know sometimes this is done just to get rid of the urine. And sometimes it's also done to get the sample to send to the microbiology lab. So here's what happens in the micro lab. So urinalysis is the easiest thing you can do, is the cheapest thing we can do, and it's the most commonly done thing in the hospital. So once you get your urine sample, and it comes to the micro lab, the first thing they do, they have these strips for urinalysis. So they have these strips are they have different sections on it, and what they do is that it's basically a dipstick. So they just dip it into the urine, and as the color of different sections change, they basically interpret it based on the color. So this is immediate. So as they dip it into the urine, the colors change and they can see it. So you get the results the same day that the urine sample is sent to the micro lab. And you don't need to memorize this or anything. It's just for your information. But basically, there are, based on the color, they will tell you, the results of the UA or urinalysis. So I'll give you one example. So for example, one thing that they look for is the presence of nitrite. So there's a section on this on the strip for nitrite. So basically, they just see how the color changed, and they will tell you if it's negative or kind of positive, and then definitely positive. And you can do this for other things. For example, if they wanted to see if there's glucose present, if it's yellow for this particular test, they would say it's normal, and so on. So here's what you really need to know. So once the results of the urinalysis is reported, you need to be able to interpret it. So a normal urine, it's supposed to be it's supposed to be clear and yellow. So if you find it to be cloudy, it can be due to different reasons. Either there's an infection, or especially in patients who have kidney disease, because there's damage to the kidney and things that are not supposed to be there find their ways into the urine, such as protein or any other chemical from the body, it will make it look cloudy. So cloudy doesn't necessarily mean infection, but it could. Another thing that's important to look at is the presence of nitrite and leukocyte esterase. So if nitrite is not supposed to be there in the urine, so if you do find nitrite in the urine, it could suggest the presence of bacteria. Now, if the nitrite is not there, doesn't necessarily mean that there is no infection, and I'll explain that more on the next slide. If you find leukocyte esterase, that means white blood cells are present, because these esterases are released from the actual white blood cell from the body. So if you do find the leukocyte esterase, that just means that there are white blood cells present, and we call this pyuria. So pyuria means the presence of pus in the urine, or more specifically, the presence of white blood cells or leukocytes in the urine. And you can actually measure how much white blood cell is in the urine. So the exact definition of pyuria would be if you have white blood cell of more than 10, then we call this pyuria. Of course, you can also see if there are bacteria in the urine. So the presence of bacteria, we call this bacteriuria. However, note that in a urinalysis, if you do find bacteria, this could be due to contamination. So this may not necessarily be bacteriuria, it could be just contamination. And the way that we check for contamination is that we look at epithelial cells. So epithelial cells are from the skin, so you shouldn't have it in the urine. So if you do find significant amount of epithelial cells in the urine, that means they're coming from the skin, which means that your sample is contaminated. So if you do find bacteria and epithelial cells significantly, you have two options. Either you really have bacteriuria in the patient and also it got contaminated, or the patient doesn't really have bacteriuria but it got contaminated. And the only way to distinguish that is by actually doing a urine culture and see if we can grow actual bacteria. But epithelial cell is what you look for to see if the sample is contaminated. And then if you have casts, there are different types of casts that are used to assess kidney function. If the patient has pyelonephritis can also cause some damage to the kidney, which kind of explains why you will see casts. So if you do find casts in the UA, doesn't necessarily mean pyelonephritis. It could mean either the patient has AKI or CKD, or it could be pyelonephritis. So these are things that are used in combination when you do patient assessment. So for example, if the patient normally has if the patient doesn't have a history of kidney disease but suddenly comes to the hospital with fever and flank pain, and you see casts on the UA, that could suggest that the patient could possibly have pyelonephritis, and the physician will do further imaging to confirm the diagnosis. Let's see what else I didn't talk about. Oh, the pH. Some organisms such as Proteus mirabilis are capable of splitting urea, which will increase pH. So occasionally you will see that the pH will be higher than the normal range, and that kind of helps you suspect Proteus mirabilis. So when you choose antimicrobial agents. Okay, so bacteriuria I talked about, sterile, pyuria. Sometimes you will not have bacteria in the urine, but you will see white blood cell increase. That's what they refer to as sterile pyuria. So pyuria, that means pus is present, white blood cell. So there's some sort of infection going on, but it's sterile because you didn't see any bacteria. So this can be due to different reasons, but one would be, for example, if a patient has a viral infection, you will still get the white blood cell response, but there will be no bacteria. So that's just important to know, because if you get sterile pyuria, sure, the patient has some sort of infection, but you don't need antibiotics to treat it because you didn't see bacteria. And of course, you would like the urine to be, you would like to see sterile urine in most patients, and it's important to rule out contamination. So here's the nitrate cycle. So basically, nitrates are important. As you eat food, nitrate will be part of the food that comes into the body, and of course, the bacteria that are part of the flora will use nitrate, as food. And this cycle continues. However, by the time it makes it back to the urine, you will still have nitrate. So nitrate goes back and forth by bacteria. Bacteria will convert nitrate to nitrite, but the end product that goes actually to the kidneys is nitrate itself. So nitrate comes from the food and also is excreted to the urine. So by the time it goes to the urine, you should only see nitrate. And what we check on urinalysis is nitrite. So because you are only supposed to have nitrate in the urine and not nitrite, and you're not really supposed to have bacteria in the urine, if you do find nitrite in the urine, that could suggest that there are nitrate reducing bacteria in the urine that are converting the nitrate, which is supposed to be there, into nitrite. So that's why we check for nitrite. If we detect it, you suspect that there are bacteria converting the nitrate in the urine to nitrite. And there are, nitrate reducing bacteria, such as Enterobacteriaceae. So most common, member of Enterobacteriaceae family is E. coli, and also Pseudomonas. So that's what we suspect. Now, the reason I mentioned earlier that if you do not find nitrite in the urine doesn't necessarily mean that there are no bacteria is because if you have too much of these bacteria, once they run out of nitrates, then they start to use nitrite as food and convert it to ammonia. So if you have too much bacteria, then nitrite, they will use all of the nitrite. So when you do your test, then nitrite shows up negative. So that's why if it's positive, it suggests there are bacteria. But if it's negative, doesn't necessarily mean that there are no bacteria. Of course, if you don't have bacteria, nitrite would be negative. But if you have too much of nitrate-reducing bacteria, you will also not see nitrite. To make it more complicated, there are also non-nitrate-reducing bacteria. So if you have any of these in the urine, they're not going to touch the nitrate, so your nitrite will be negative again. So it's not a perfect test. If nitrite is positive, it suggests that there are bacteria, but if it's negative, you need to keep looking.
We looked at signs and symptoms of cystitis and pyelonephritis. We distinguished between bacteriuria, sterile pyuria, and sterile urine using the results of a UA. Now the next learning objective is ensure urine cultures are taken in patients with pyelonephritis or recurrent cystitis.
Okay, so here's the severity of urinary tract infections. So it goes from less severe to more severe. So note that cystitis is all the way to the left. So cystitis in general is a benign infection. If you don't treat it, it may actually resolve on its own, or it's possible that it can actually progress to pyelonephritis. Pyelonephritis, however, is a severe infection. Keep in mind that by the time it's pyelonephritis, it has actually infected the kidneys by now. And it can actually progress to bacteremia, and that's assuming if it's an ascending infection. So if the bacteria are actually coming from the bladder, so it's ascending, it's going up to the kidneys, and then the next step is to go into the blood, causing bacteremia. The other way to get it is actually the descending pathway. So if someone has bacteremia, the bacteria can come from the blood and go to the kidneys and cause pyelonephritis. So for pyelonephritis, we do need urine and sometimes blood cultures. And when I say sometimes, if someone suspects that it's already made it to the blood, that's when you're gonna need blood cultures. But you definitely need urine cultures to treat pyelonephritis. And then, of course, the very severe infection is urosepsis. Urosepsis basically means sepsis caused by UTIs. For urosepsis, both the urine and blood cultures are needed. So note that the reason we always get blood cultures is, this is an extremely severe infection. Patients, in fact, need to be admitted to the hospital because this is an emergency and it can lead to death. That's how severe this is if it's not, managed appropriately. So this is, definitely patients need to be in the hospital. Whereas for cystitis, because it's a benign infection, the patients do not need to go to the hospital. They can be treated outpatient. So typically patients end up going to their primary care physician. A lot of patients who get multiple cystitis throughout the year, they can actually get treatment over the phone. So if you already have a primary care physician established, sometimes you can call your doctor and the doctor will send a prescription to your pharmacy. Or sometimes the doctor can actually, if you already have established primary care physician and they know that you get or the patient gets cystitis like 4 or 6 times a year, they can actually give antibiotics ahead of time, and then the patient can go ahead and take the antibiotics as they get cystitis. Because it's, for someone who gets cystitis multiple times, it's easy for them to identify the symptoms. And it also eliminates unnecessary costs of going to the doctors, for a benign infection. Especially, it will eliminate patients going to the emergency department. And then, of course, in the middle we have pyelonephritis, which is a severe infection, but it's not really an emergency. So it's recommended that patients should go to the urgent care clinic. So, urgent care clinics are, typically open 24 hours. So, patients typically end up going to the emergency department because, a lot of people are not aware that there are urgent care clinics. And that can actually reduce the cost because going to the emergency department is very expensive and it should be reserved for very severe infections. But the reason pyelonephritis needs to go, patients need to go to the urgent care clinic rather than outpatient is because urine cultures are needed. It's not something that the doctor can do in the office or over the phone. So at least the patient needs to go to the urgent care clinic and potentially to the hospital if needed. So who exactly needs urine cultures? So as I mentioned, pyelonephritis is a severe infection and cultures are needed to ensure appropriate treatment is selected. Urine culture is not needed for cystitis. It is needed for recurrent cystitis. And the reason is if someone keeps getting cystitis, it's likely to be due to resistant organisms. So for that reason, we need cultures to identify susceptible antimicrobial agents to make sure we treat it appropriately. And of course, complicated UTIs are also more likely to be due to resistant organism, and that's why we also need urine cultures to make sure we use agents that are susceptible.
We explored signs and symptoms of cystitis and pyelonephritis. We looked at the results of your urinalysis to distinguish between bacteriuria, sterile pyuria, and sterile urine. We ensured urine cultures are taken in patients with pyelonephritis or recurrent cystitis. Now, the next learning objective is list the top 4 common uropathogens that cause urinary tract infections.
So here on the left, I have uncomplicated UTI, which is the focus of this topic, and this could be cystitis or pyelonephritis. But as you can see, the number one organism that causes these uncomplicated UTIs is E. coli. So E. coli is the number one organism. You should always cover for E. coli. So whatever agent you choose, you need to make sure that it has a good coverage for E. coli. And then outside of that, you have Klebsiella pneumoniae causing a lot of these infections, and also Staphylococcus saprophyticus, as well as Enterococcus. So these are your top 4 organisms that commonly cause urinary tract infections. Now, note that like other organisms can cause UTIs, but they're not as common. So Pseudomonas, for example, Pseudomonas aeruginosa, there's about like 1% case. So you don't really cover, you don't need agents that cover Pseudomonas for every patient. Occasionally, by occasion I mean like there's like 1% chance that they may need it, and by then, we will have cultures and basically, if that 1% shows up, is when your antibiotic is not working, and then we get cultures, and then you find Pseudomonas. But you do not want to cover for Pseudomonas for every patient with UTI. You want to target the top 4. And of course, when it comes to complicated UTI, you start to, still E. coli is your number 1 organism, along with Klebsiella and Enterococcus. However, note that in complicated UTI, you do start to see more of Candida species causing UTI due to Candida, or Candiduria as we call it. Now, I know, so in complicated UTI, they are more likely to be due to resistant organism. So, for example, look at Pseudomonas. So Pseudomonas are more likely to cause complicated UTI, but still is around 2%. So it's still something that you do not want to cover empirically for everyone. So you do not need to cover for Pseudomonas for patients with complicated UTI. If you happen to find it on the urine culture, that's when we cover. We use an agent to treat it. Otherwise, empirically, we target the majority. So you need to target the top 4, and in this case, also Candida when we talk about complicated UTI. But I want you guys to focus on uncomplicated UTI. So just know these top 4 agents cause uncomplicated UTI.
We identified signs and symptoms of cystitis and pyelonephritis. We analyzed the results of a urinalysis. We ensured urine cultures are taken in patients with pyelonephritis and recurrent cystitis, and we looked at the common uropathogens. Now, the next learning objective is, given a patient case, recommend effective drug therapy for treatment of cystitis or pyelonephritis. Now let's take a look at treatment of cystitis. Here are the recommendations from the 2010 IDSA guidelines. Fluoroquinolones such as ciprofloxacin and levofloxacin should not be used as first-line agents for empiric treatment of cystitis, given their high propensity for collateral damage and the benign nature of cystitis. So although fluoroquinolones are extremely effective in treating cystitis, but they have a lot of adverse effects, including collateral damage, meaning that they will disrupt the microbiome, select for resistance, as well as leading to Clostridioides difficile infection. Now, oral beta-lactams have lower efficacy in general and should not be used as first-line agents, especially amoxicillin and ampicillin due to poor efficacy. And this is likely because of poor bioavailability of oral beta-lactams in general. Now, if somebody doesn't have any other options and we must use oral beta-lactams, it is best to use amoxicillin clavulanate, cefaclor, which is a second-generation cephalosporin, cefdinir, which is a third-generation cephalosporin, or cefpodoxime, which is also a third-generation cephalosporin. However, in general, it is best to avoid oral beta-lactams because of lower efficacy. Now, the IDSA guidelines actually recommend trimsulfa, or trimethoprim sulfamethoxazole, as a first-line option, but this should be avoided for empiric treatment of cystitis because local E. coli resistance rate is more than 20% across the United States. And 20% is the threshold that IDSA recommends for resistance in order for it to be significant enough to avoid trimsulfa. So it should be avoided because in the United States, everywhere the resistance rate is more than 20%. So essentially we have 3 first-line drugs for cystitis available in the United States. So we have nitrofurantoin, we have fosfomycin, and pivmesolinab. Nitrofurantoin should be used for 5 days. And this is BID dosing, so this is specifically the macrobid formulation. The adverse effects in general includes GI disturbances, so nausea and vomiting. Some patients may experience headache. Some of the rare, one of the rare adverse effects of nitrofurantoin could be pulmonary fibrosis, and typically when this does happen, It happens when people take this long term. So if people are taking it for several months as opposed to 5 days. So with 5 days of use, it's really extremely rare. Now, remember that the package insert says this is contraindicated in creatinine class less than 60, but per Beer's criteria, it's okay to use in creatinine class 30 to 60. Phosphomycin is a single dose, so 3 gram one dose is the current recommendation. Whether more doses are required, we need more studies to find out. In general, the adverse effects of phosphomycin, diarrhea, nausea, headache, in general, well tolerated. This is a powder that comes in a sachet, so this needs to be mixed in water and consumed. It's relatively more expensive, so it's somewhere between $30 to $40, but then again, it's just the one dose. And more recently, in 2024, pivmesolinam was approved in the US, although this has been on the market outside of the US since the late 1970s. Pivmesolinam IDSA guidelines recommend 400 milligram twice a day for 3 days. Now, note that this is different than what the package insert is approved for. So this is the package insert is for 200 milligram 3 times a day for 3 to 7 days. Now we know that TID is not does not improve adherence, so BID is easier to adhere. So the guidelines do recommend higher doses but less frequently to improve adherence. And the duration is for 3 days. So there is a network meta-analysis that was published in Lancet Infectious Diseases that showed that 3 days is just as good as 5 days or 7 days. So there's really no need to go beyond 3 days if we're doing the high dose. In general, pivmesolinam is very well tolerated. Now, these 3 agents are considered first line because they have narrow spectrum of activity, and they primarily concentrate in the urine, so they are unlikely to go to other sites in the body, so their propensity to cause collateral damage is very low, and resistance to these agents remain pretty low in E. coli. Now, when it comes to treatment of pyelonephritis, again, the same issue with trimsulfa because the rate of resistance is more than 20% across the US. Empirically, it should not be used. However, in pyelonephritis, there will always be a urine culture. So if the urine culture results come back and it's susceptible to trimsulfa, only then it is okay to use trimsulfa. But empirically, before the urine culture results are back, it should not be used if other options are available. Now, IDSA guidelines also recommend fluoroquinolones as first line for empiric treatment of pyelonephritis, but they do say that they should be avoided empirically because local E. coli resistance rate is more than 10%. So 10% is the threshold for fluoroquinolones, and across the United States, resistance rate is more than 10%. So they should not be used empirically, but once the results of the culture come back, if they are susceptible to fluoroquinolones, only then it would be okay. But then again, fluoroquinolones, we have the issues of collateral damage and adverse effects, so they should only be used if other options are not available. Now, regardless of the empiric agent chosen, therapy must be directly based on the results of a urine culture. So it's extremely important because pyelonephritis is relatively more severe infection, and it can lead to bacteriuria, which can become a pretty severe infection. So here are the first line drugs for pyelonephritis per 2010 IDSA guidelines. So essentially, for the most part, ceftriaxone is what's commonly used. It is very affordable and it's easy to use. It's once a day dosing, so 1 gram once a day or every 24 hours. Now, duration of treatment for pyelonephritis is 7 days. In general, ceftriaxone is well tolerated. However, it is a third generation cephalosporin, so it's relatively more broad. So when the urine cultures do come back, it's best to de-escalate to the narrowest antibiotic that's susceptible. And Cefotaxime is also a third generation cephalosporin, so it's going to be pretty effective, but it's dosed every 8 hours, so this one is rarely used. And of course, if somebody has cephalosporin allergy, we can use aminoglycosides, so either gentamicin or tobramycin. However, keep in mind that aminoglycosides are extremely toxic, so nephrotoxicity, ototoxicity, and rarely neuromuscular blockade can also occur with aminoglycosides. So in general, they should be avoided if there are other options. If you cannot avoid other options, only then it is okay to use aminoglycosides simply because of toxicity. Otherwise, they are pretty effective in treating all types of UTI. Now let's take a look at the resistant patterns in urinary E. coli isolates across the United States. So this was a study that compared the resistant rate for three drugs, so nitrofurantoin, trimsulfa, and ciprofloxacin. And they compared the rates from 2003 to 2012. And this study was published in 2016, so it does take a few years to collect these data and publish it. They also compared two groups, so the age group 18 to 64 years of age and age 65 and older. And what we see is that when you compare 2003 data to 2012, there's not significant increase in resistance to nitrofurantoin. So that's why nitrofurantoin has pretty much remained pretty effective against E. coli. So that is recommended first line for cystitis only. And for trimsulfa, you can see that since 2012, actually resistance rate for both age groups has been more than 20%, and 20% was the threshold for resistance in order for it to not be used empirically. So you can only use it once urine culture results are back and show that it's susceptible to trimsulfa. Now, when you look at ciprofloxacin, you can see that since 2012, the resistance rate has been more than 10% for both age groups. So the threshold for ciprofloxacin is 10%. And so for that reason, both ciprofloxacin and trimsulfa should not be used empirically for pyelonephritis or cystitis for that matter. So we looked at symptoms of cystitis and pyelonephritis. We analyzed the results of urinalysis. We ensured urine cultures are taken in patients with pyelonephritis and recurrent cystitis. We also recommended effective drug therapy for treatment of cystitis and pyelonephritis. Now, the next learning objective is change empiric therapy to pathogen-directed therapy based on urine cultures and susceptibility results. The concept of collateral damage refers to unintended ecological adverse effects of antibiotic therapies, and this includes selection of drug-resistant organisms as well as unwanted development of colonization or even infection with multi-drug resistant organisms. Here's how selective pressure works. The normal flora includes a diverse population of bacteria, and this diversity is beneficial for health, because these organisms can actually compete with pathogenic bacteria for growth. So they actually prohibit the growth of pathogens. Although these bacteria are beneficial for health, some of them could actually include genes for resistance. So imagine these two strains of bacteria that are pink, they actually include genes for resistance. Although they are resistant to antibiotics, they are not really causing any infection or any problems in the host. Now imagine that you start using antibiotics for an infection. While the antibiotic is important for killing the infection, the antibiotic can also kill all these beneficial flora. And when it happens, all the flora that are susceptible to the antibiotic will die, except those beneficial bacteria that were resistant. And because those resistant bacteria, although they are not causing any problem, because they stay around, they actually become the dominant species as part of the flora. And now, the majority of the flora include genes for resistance. And then when the day comes when an actual pathogen invades the host and causes infection, these flora can actually transfer those resistant genes to the pathogenic bacteria from plasmids and cause infections that are resistant to antibiotic. And this is referred to as selective pressure, where the resistant organism becomes the dominant species. This selective pressure is greatest with broadest antibiotics, and the risk is lowest with narrowest antibiotics. So therefore, it is important to keep that in mind, and when we select antimicrobial agents for our patients, to choose the narrowest possible option. This pyramid is designed to help you understand broad versus narrow spectrum of activity. It is important to know that there is no such thing as a tiering system when it comes to broad versus narrow spectrum of activity. I have created this pyramid just to help you understand broad versus narrow. Now, the higher you are on the pyramid, the narrower the spectrum of activity, and the lower you are, the more broad the spectrum of activity. And broad versus narrow is not really a head count of how many organisms are covered by a specific antibiotic, but rather it is the propensity of causing collateral damage. So tier 1, which is considered pretty narrow, is essentially the urinary antibiotics, so nitrofurantoin and oral phosphomycin, as well as penicillin. So penicillin is considered the narrowest antibiotic when it comes to beta-lactams, and nitrofurantoin doesn't really go anywhere in the body other than the urine, so these agents are unlikely to cause collateral damage in the body. Slightly higher, so these are, tier 2 is still pretty narrow, but relative to tier 1, slightly broader, and these are first generation cephalosporins such as cefazolin, and also ampicillin and trimsulfa. So tier 2 is also pretty narrow, and these are good agents to de-escalate when we are using broad spectrum antibiotics. Now, I'm not going to be able to fit everything in there, so for example, I'm skipping second generation cephalosporin, so you can think of second generation between tier 2 and tier 3. And tier 3 includes third generation cephalosporins such as ceftriaxone, as well as ampicillin sulbactam and amoxicillin clavulinate. Now, these agents up to tier 3 do not have activity against ESBL producing agents, but when you get to the third tier, it's actually pretty broad spectrum. Now, tier 4, slightly more broad than tier 3. What's unique here is that ertapenem and gentamicin, they do have activity against ESBL producing agents. Ertapenem is a carbapenem that does not have activity against Pseudomonas, and gentamicin is an aminoglycoside that recently it is decided that it no longer has activity against Pseudomonas. So for that reason, because they don't have activity against Pseudomonas, they are placed in tier 4. Now, from tier 5, this is where we get pseudomonal activity. So everything in tier 5 has activity against Pseudomonas, and this is considered pretty broad. So unless you are trying to cover for Pseudomonas, you shouldn't really be using these agents if you have options. So cefepime, which is a 4th generation cephalosporin, ceftazidime, which is a 3rd generation cephalosporin, piperacillin tazobactam, fluoroquinolones such as ciprofloxacin, levofloxacin, and also the aminoglycoside tobramycin is pretty active against Pseudomonas, and amikacin is considered active against Pseudomonas in the urine only. Aztreonam is also a beta-lactam that's active against Pseudomonas. And tier 6 is actually more broad than tier 5. So these are pretty much carbapenems as well as ceftolozane tazobactam. These are not only active against Pseudomonas, but also active against multi-drug resistant Pseudomonas. So if you have Pseudomonas that's resistant against tier 5, tier 6 will still remain an option. So for that reason, they're considered more broad. And in the same sense, tier 7 is more broad than tier 6, because if you have pathogens that are resistant to tier 5 and 6, tier 7 may still be active. So you really want to reserve these. And in most hospitals, tier 7 and as well as sometimes some agents from tier 6, such as ceftolozane tazobactam, they're typically restricted. So you would need approval from the ID team to be able to use these agents, not only because you want to reserve them for resistant pathogen, but also these are pretty expensive. Another thing to keep in mind when selecting agents for treating urinary tract infection is penetration to the site of infection. Nitrofurantoin and oral phosphomycin are excellent for cystitis. However, neither of them stay in the renal tissue, so they go straight into the bladder. They don't. So they go completely into the bladder. They don't stay in the renal tissue. So therefore, nitrofurantoin and phosphomycin, specifically oral phosphomycin, should not be used for pyelonephritis. Moxifloxacin also does not go into the bladder, so moxifloxacin should not be used for cystitis. In this table, I'm showing you the percentage of different antibiotics that actually get excreted renally, as well as some antifungals. What I want you to know from this table are the bolded agents, and not necessarily the percentage, but the fact that these bolded agents get enough concentration in the urine. Now, here are the recommendations from the 2023 IDSA guidance on the treatment of antimicrobial resistant gram-negative infections. Specifically, we will focus on ESBL producing Enterobacterialis causing UTIs. So when it comes to uncomplicated cystitis, for ESBL UTIs, the preferred agents are still nitrofurantoin and trimsulfate, assuming that the ESBL producing organism is susceptible to nitrofurantoin and trimsulfate on urine culture. So you do need to have urine cultures, first of all, to confirm that this is ESBL, but also if it happens to be susceptible to nitrofurantoin and trimsulfate, then these are the treatments of choice. Now, it is common for ESBLs to be resistant to also nitrofurantoin and trimsulfate, but you just wouldn't know until you have the results of the urine culture. Now, if it happens to be resistant to these agents, then you have alternative agents. So for cystitis specifically, you can use just a single dose of aminoglycosides, assuming that these are susceptible on the urine culture. So, anything that's resistant on urine culture, you just eliminate from this list. Oral phosphomycin would be an alternative option for E. coli only. Of course, fluoroquinolones as well as carbapenems. And you do want to avoid these agents because they are not effective for cystitis. So doxycycline and amoxicillin clavulanate, as well as cefepime. So these are proven to be have inferior efficacy. When it comes to cefamycins such as cefoxitin and cefotetan, there is insufficient evidence out there, so we just don't know if they will be effective. So until more evidence is available, they should be avoided. Now, for pyelonephritis and complicated UTIs, the preferred agents, again, assuming that these are susceptible on urine culture results, is trimsulfa, fluoroquinolone, and ertapenem or meropenem or imipenem. For if the culture is also resistant to this, then alternatively once daily aminoglycosides. Now this will be the full course, not just a single dose. And of course, again, you want to avoid, because this is pyelonephritis, you want to avoid nitrofurantoin and oral phosphomycin, as well as doxycycline. And because this is ESBL, cefepime has inferior efficacy, and for cefamycins, there is insufficient evidence at this point. Majority of cases of uncomplicated UTIs include cystitis, so nitrofurantoin, 5 days of treatment is adequate. With phosphomycin, total duration of therapy is just a single dose. Now, these are in most cases. For example, if someone has ESBL UTI, a single dose of phosphomycin may not be adequate. For pyelonephritis with IV beta-lactams, total duration is 7 days. The same is true with fluoroquinolones, whether it's IV or PO.
And that would be 7 days total. So let's say if someone got IV beta-lactam for the first 3 days, and then they were switched to a fluoroquinolone, then they just do 4 more days of fluoroquinolones with plus the 3 days of IV beta-lactam to give you a total 7 days.
With Bactrim, 14 days is required, as well as PO beta-lactam. So because PO beta-lactams are inferior to IV beta-lactams, you need 14 days of treatment, and PO beta-lactams are last option.
Let's say if someone got 3 days of IV beta-lactam, then they get 11 days of trimsulfa to complete 14 days of treatment.
With complicated pyelonephritis, we do not have clinical practice guidelines. So in general, most clinicians agree on 7 to 14 days of treatment. However, there is clinical evidence that 7 days of treatment is sufficient for most patients with complicated pyelonephritis. So I would recommend 7 days of treatment for complicated pyelonephritis.
So let's take a look at the case study. So let's say CR is a 50-year-old woman with no significant past medical history and no known drug allergies, who is being treated empirically for pyelonephritis with ceftriaxone 1 gram IV every 24 hours. So let's say today is day 4 of treatment, and she's clinically well. Here's the results of the urine culture. So the organism is E. coli, and the susceptibility results have come back. So basically, R means resistance. So amoxicillin clavulanic acid is resistant. Ampicillin sulbactam is resistant. Cefpodoxime is susceptible. Ceftriaxone is susceptible. Ciprofloxacin is resistant, and trimsulfa is susceptible. So what would you use? So far it's been ceftriaxone. Ceftriaxone is IV, and at some point, if the patient is ready to go home, we can change this to PO. So ceftriaxone only is available as IV. So but first of all, you want something that's susceptible. You don't want to use something that's resistant. So augmentin, for example, is PO, but because it's resistant, we're not going to be able to use it. So from the things that are susceptible, trimsulfa is available PO. And so is cefpodoxime. Cefpodoxime is a 3rd generation cephalosporin that's available as PO. So you have 2 options left. So between the two, the correct answer would be Bactrim, because PO beta lactams don't get enough concentration in the urine. So if you do have options, PO beta lactams should be your last option. So for example, if this patient happened to have sulfa allergy, then trimsulfa would not be an option, and then you can use cefpodoxime. But since this patient does not have sulfa allergy, we would go ahead and choose Bactrim, or trimsulfa would be the best option.
The last learning objective is to describe how over-the-counter products should be used in the treatment and prevention of urinary tract infection. So when it comes to over-the-counter products, a lot of people are interested in cranberry products, so juice or tablet. And this is essentially the idea behind this is that cranberry may inhibit adherence of uropathogens such as E. coli to urinary tract surface. If so, it may be able to prevent urinary tract infections. Now, historically, there's been limited clinical data on this. Back in 2013, JAMA released a clinical evidence synopsis. So essentially, the question they were asking, are cranberry products such as juice, tablets, capsules, and syrup associated with prevention of urinary tract infections compared with placebo or other treatments? And the conclusion at the time was that cranberry products are not associated with prevention of UTIs. However, lack of association of cranberry products with a reduced incidence of UTIs in clinical trials may be due to lack of participant adherence, lack of sufficient active ingredients in the cranberry product, or lack of sufficient statistical power. This actually led to an RCT that was published in JAMA in 2016. This is essentially was the effect of cranberry capsules on bacteriuria plus pyuria. So this was an objective way of measuring whether cranberry can prevent adherence of E. coli to the urinary tract. So they wanted to test the effect of 2 oral cranberry capsules once a day on presence of bacteriuria plus pyuria among women residing in nursing homes. And essentially, they found no statistically significant difference between placebo and cranberry. In fact, an editorial was published in JAMA, and essentially they said that the evidence is convincing that cranberry products should not be recommended as a medical intervention for the prevention of UTI. A person may, of course, choose to use cranberry juice or capsules for whatever reason she or he wishes. However, clinicians should not be promoting cranberry use by suggesting that there is proven or even possible benefit. Now fast forward to 2023, there was a Cochrane review that essentially looked at everything that was published on cranberry. So essentially cranberry products compared to placebo control or no treatment. And overall, they found that although it looks like it may reduce the risk of getting a UTI, there is significant heterogeneity. So they, you cannot conclude that this is evidence that cranberries reduce the rate of UTI. So I squared or Higgins statistic measures heterogeneity. So ideally we want there to be zero heterogeneity, but essentially less than 25% would be okay. This was 69% heterogeneity. With women with recurrent UTI, although the results show reduced rate of UTI, but still significant heterogeneity. So that's why I have this in yellow. In elderly men and women in institutions, the study found no statistically significant difference between cranberry products and nothing. So essentially this crossed, the confidence interval crossed 1, so no significant difference. There is significant evidence to support that this may be beneficial in children, and that's beyond the scope of this topic. We are focusing on adults. For people who have issues with bladder emptying, such as patients with multiple sclerosis, no statistically significant difference. Now, in people who have susceptibility to a UTI due to an intervention, the evidence is clear that it may prevent UTI in those people. So no heterogeneity and statistically significant difference. No difference in pregnancy, and when it comes to safety, also no difference in adverse effects. So while cranberry products may not be as effective in most people, but also they're not causing adverse effects. So essentially, unless people are about to undergo a procedure that will put them at risk of getting a UTI, the evidence is clear that cranberry products are not going to work for the large majority of people out there. And lastly, for over-the-counter products, we have phenazopyridine. This is essentially a urinary analgesic to relieve the symptoms of UTI, such as pain, burning, urgency, and frequency. This has no antibiotic activity. So essentially, this is just to relieve the symptoms, and people should not take it up to 2 days. And essentially, because with proper treatment, symptoms should be gone by 2 days. So if someone has symptoms beyond 2 days, that could essentially indicate that the treatment is not working. So you don't want to mask that. So you want to make sure that people don't take it beyond 2 days. So if there are symptoms, they can go to their primary care provider or an urgent care to receive appropriate treatment. Now, some of the adverse effects of this could include headache, dizziness, or stomach cramp. And one thing that's important to communicate to patients as part of education is that it does have a dye that can turn the urine reddish. So that's important because, imagine someone who has pain or burning when peeing and suddenly see their pee turn red. They might, that might be alarming. That might make them think it's blood, for example. So you want to make sure that patients are aware of this. Okay, I'm here at my local CVS. Let's see where the pharmacy is. Okay, let's see. Here are the AZO products. There's one for urinary tract infection test. There's one for urinary tract, urinary pain relief. So the urinary pain relief has phenazopyridine in it. That concludes this presentation.